Hi, my name is Gian Salzmann. I'm a knee surgeon and I'm working in Germany as well as in Zurich, Switzerland. AutoCart has impacted my practice in a way that I now have the ability to react spontaneously to traumatic cartilage defects, but also to degenerative cartilage defects in a single stage procedure with a very high biologic potential. You're taking out cartilage, prepare it, mince it, activate it and put it right back in. It was arthroscopically feasible, and you have to combine it with autologous fluid to boost the biologic potential and at the same time to fix the chips in place as a matrix. The ideal patient for the AutoCart procedure is a young subject, meaning below the age of 30, but also older subjects do very well. Optimally traumatic lesion, very short symptom duration and no underlying co-pathology. If you compare ACI to AutoCart, you're transplanting chondrocytes. The major difference is AutoCart is a single-stage procedure, ACI is a two-step procedure. In ACI, you have the chondrocytes in the lab, they are dedifferentiating, they are getting older, and often you are transplanting the chondrocytes with a matrix, and the matrix has to be digested first before the chondrocytes can get active. The outcomes currently, what we've seen doing the AutoCart procedure now since 2.5 years, are very comparable to ACI. We see similar scores in clinical outcome as well as in MRI outcome. The same is with revisions, with a very low rate of revisions. But what we see is a clear difference that the early rehabilitation, meaning the first 3 to 6 months, is much quicker when you compare it to ACI or microfracturing. AutoCart has shown with its early success based on the high biologic potential that in the future maybe we can treat even more problematic lesions, meaning bipolar lesions, early OA lesions and other joints for effective cartilage repair. If you have some learning experience, it is a very simple and at the same time very effective procedure.